Hi class, it's good to see you again. Or actually, I guess that's a lie. Hopefully it's good for you to see me because I can't see you. Anyway, this is for the PTA Patho class. And what I wanted to do is I felt bad for you guys because we lectured on cardiac and pulmonary over a month ago, and now the exam is coming up all this time later. So I put together this video review to help you guys remember some things and know what to focus on. So here we go. I want to start with cardio. Remember what a cabbage was. Not a vegetable, but actually a surgery, coronary artery bypass graft, where they take veins, usually from the patient's own body, and they put a graft that goes around a blocked coronary artery. Can be ×1, ×2, ×3, depending how many areas they have to bypass. What you want to remember for this when you're treating patients is precautions. Sternal precautions. This person has this big incision now that's healing right on their chest. So anything that moves the sternum or moves the ribs, bringing the arms up overhead, straining, pushing hard with the arms, is going to put pressure on that incision. So know what those precautions are. Congestive heart failure. We have right-sided and left-sided. Now when you think about it, the heart is just basically a big pump. Right side of the heart pumps blood to the lungs, left side of the heart pumps blood to the body. Right side of the heart, when it fails, blood is going to back up into the periphery. So that's going to cause swelling and edema throughout the body. That's your main symptom that goes with that. Right-sided failure can be due to myocardial infarction and some cell death, so that pump is weakened. Or it can be due to lung problems that are not allowing the heart to circulate blood out. Left-sided heart failure usually causes pulmonary problems because if the left side of the heart, that pump is not working, it's not going to send blood out to the body, that blood is going to accumulate, build up, and back up into the lungs. So you may say dyspnea. Dyspnea, difficulty breathing, tachycardia as symptoms. So those are the main points with those. How do we measure heart function? Ejection fraction. So ejection fraction is simply the amount of the blood that the heart pumps with each beat. It doesn't pump 100% of the blood that goes into the left ventricle. It pumps about 55 to 75% of the blood that enters. So they can measure this, and the lower the number, the higher your risk. So if you have a 20% ejection fraction, you're only pumping half the amount of blood out of your left ventricle with each beat that you would be if you had a 40% ejection fraction. So it's a way of us knowing how severe that congestive heart failure is. Peripheral artery disease, PAD, that's what that stands for. So this is problems with the peripheral circulation. If you think about it, we think about arteriosclerosis just happening in the heart, causing a heart attack. We can also have arteriosclerosis happening in our brain that causes a stroke, or in our lower extremities, and that can cause peripheral artery disease. What is the chief sign of this? Intermittent claudication. Intermittent, meaning it comes and goes, claudication, blockage. So intermittent claudication is something we see with peripheral artery disease, and this is when the patient gets up, they start walking, they'll develop pain. Why? Because of the blockage in the arteries, they're not getting good blood flow to those muscles. So when they challenge the muscles by exercising or by walking, there's inadequate oxygen getting to the tissues and they'll have pain. When they sit down and rest, that pain will go away. So that's intermittent claudication. I wanted to also review the differences between an arterial ulcer and a venous stasis ulcer because they're quite different in terms of what we do as far as treatment. So an arterial ulcer, you're not getting good blood flow to the legs, and that's why you're getting ulcers forming. Think of it as a tree that doesn't get watered. That tree gets dried out, and that's what you see with arterial insufficiency. The skin will be pale. It doesn't have good blood supply, so it will be white. You won't see hair growth on the leg because the hairs just aren't growing. You don't have blood supply. The legs will be thin because the muscles are atrophying, and the skin will be dry. With venous stasis ulcers, we have a different problem. We have blood accumulating in the lower extremities that's not getting circulated back to the heart. So you're going to have reddish brown looking skin. The legs are going to be wine shaped. There's a lot of swelling. The skin will be weepy rather than dry, and these will be painful. So when you're treating people with these leg ulcers, you need to understand which type it is. If you have an arterial insufficiency ulcer, is it going to feel good if you elevate those patients' legs? Heck no, it's going to hurt. Because the problem is, if the legs are up above the level of the heart, now even more blood is draining out of the legs. So you're not going to want to elevate their legs and have them exercise. You're not going to want to do any massage because the skin is very fragile. With a venous stasis ulcer, it's just the opposite. Actually elevating the legs above the level of the heart might help bring some of that swelling down. Some gentle massage might be helpful. You might even want them to elevate their legs and do some ankle pumps, get the blood moving back out of the area. Arterial insufficiency, exercise is still going to be good, but you're probably going to have them sitting down with their legs in a dependent position, the feet well below the heart, and maybe doing some leg exercises and sitting. Deep venous thrombosis, DVTs. So this is when a clot forms, usually in the calf, the lower leg, but it can also happen in the femoral vein, up higher in the leg, and in the arms, but the arms is very rare. I think I've seen one in my entire career. So what happens is that clot forms. Why do we care about this? Because that clot can dislodge and become an embolism. And when it's an embolism, it travels through the circulations. It can lodge in the lungs and become a pulmonary embolism, which has a very high fatality, or it could even travel to the brain and cause a stroke. So, no signs and symptoms of a DVT. Know that if you're suspicious of a DVT, you need to contact your therapist, talk to the nurse. Therapy is going to be put on hold until they can get treatment. We're going to want to exercise patients before a DVT because we want to prevent it in the first place. And once they have therapeutic levels of medication in their blood to break down that clot, then we'll exercise them again. So, pulmonary embolism. A clot travels, lodges in the lungs, so the circulation downstream of that clot doesn't happen. The blood can't get through, so those tissues start to die. They're not picking up oxygen. And on the other side of the clot, blood is backing up. There's a lot of swelling, a lot of pressure there. Those tissues will die. And net effect over time, if it's a large embolism, is you're not going to get blood flow and oxygen delivered to the body. So all the organ systems are going to start to die because of oxygen starvation, and the patient will go into shock and all those organ systems will shut down. So pulmonary embolism is a very dangerous thing. We really want to avoid it. INR, I'll talk about in a little bit when I review labs. Pulmonary. So remember, inspiration is an active process. We're using the diaphragm and the external intercostals to expand the lungs, and the elastic recoil of lungs is expiration. It's passive. Just happens, unless we're purposefully trying to blow oxygen air out of our lungs. Dyspnea is a term that means difficulty breathing. Apnea means we're not breathing without breathing. Surfactant is a chemical that is inside the alveoli, the little grate-like structures in the lungs where air exchange occurs. And the role of surfactant is to keep those alveoli inflated. It allows for gas exchange. If you don't have surfactant, those alveoli will collapse. You can't have good air exchange. Tuberculosis. Tuberculosis, a big problem with tuberculosis is that people don't continue taking their medications, and they need to take medications often for 6 months or more. And we have a lot of resistant strains that are developing because of mutations. TB is like COVID-19, as we've just learned. It is an airborne or droplet precaution. So, TB patients might even be in a negative pressure room in the hospital where air goes in, it's filtered before any air is allowed out. With pulmonary, a lot of students get confused between restrictive and obstructive disorders. So I'm just going to go over those briefly. Restrictive pulmonary disorders means that something is restricting the lungs so that they can't expand and pull in air. Something structural, like a really severe scoliosis or kyphosis. It's not allowing the lungs to fully expand and get air in. You can also have restrictive disorders from polio or multiple sclerosis or Guillain-Barré syndrome, something that causes severe muscle weakness. So the muscles of respiration are not working to pull air in. Obstructive disorders, far more common, is difficulty getting air out. Air gets trapped in the lungs. So when you're trying to breathe out, it's hard to get air completely out of the lungs. The rate at which air leaves the lungs is slowed. And your two main categories of that are emphysema and bronchitis. So bronchitis is the chronic infection, chronic inflammation, and mucus formation that's blocking off those airways and trapping air in the lungs. Emphysema is when the alveoli, those little grape-like structures in the lungs, start to break down. The little walls between them start to break down and disintegrate. And instead of having a lot of little small air pockets, now you've got large air pockets. What does that mean? Less surface area for oxygen exchange to occur in. And again, air gets trapped in those pockets. Ironically, one of the signs of COPD, emphysema, is a barrel chest. And we tend to think barrel chest, someone that's buff, right? Someone that's in good shape. It's trapped air in the lungs, has nothing to do with that. So COPD, can't get air out. Review of labs, hemoglobin and hematocrit, know what the norms are for that. Typically with a hemoglobin of less than 8, you're going to hold therapy. Patient might have a 10 or 11, their body might be adapted to that, but you're still going to do your treatment. Though you might expect someone with a low hemoglobin might fatigue a little more easily. INR stands for Internationalized Normalized Ratio, and this is a comparison of how long blood takes to clot in a normal person. So a 1-on-1 INR means your blood clots at the same rate as a normal individual. Where we use this is with treatment for DVT. We want to slow down that patient's blood's ability to clot. So we want a higher INR number, like a 2 or a 3. So blood is taking longer to clot, and that DVT can break down and go away. So no, INR, what are normal numbers? No elevated numbers, go with blood thinners, aspirin being a mild form, Coumadin or warfarin, stronger medications to be blood thinners. But what also is going to happen with these patients, you have longer time for blood to clot. They're at increased risk of bruising and bleeding. A lot of times you'll see they'll have a lot of bruises on their arms from where IVs have been. Prothrombin time, another measure of blood clotting. Prothrombin time is the number of seconds it takes for blood to clot. So when that number is small, that means the blood is clotting fast. So a low prothrombin time means increased risk of clot formation, increased DVT risk. A long prothrombin time means that blood is taking a long time to clot. So in that case, they're going to bleed or bruise easily. The opposite effect. Thrombocytopenia, low level of thrombocytes, low number of platelets. So those people, their blood is going to take longer to clot, more risk of bleeding. White blood cells, low levels of white blood cells, neutropenia or leukopenia are terms for those. What happens if your patient has a low white count? Increased risk of infection. You're probably going to want to wear a mask, not so much to protect yourself, but to protect them from anything that you're exhaling. HIV. Remember, with HIV, white cell count drops. That's how we know when someone is now no longer just HIV positive, but actually has AIDS. There's lots of different types of white blood cells involved in the immune system. With HIV, it's a subset of the T cells, CD4 cells. When those numbers drop below 200, the person now has AIDS. Go ahead and just quickly review what are the different types of blood cells involved in the immune response. B cells become plasma cells and secrete antibodies. They form memory cells. T cells, we have a lot of subsets of these. We have T helper cells, which help activate the immune response. We have T suppressor cells, which shut it down. We have natural killer cells, or type of T cell. They don't need to be activated. They can just go right away and start killing the foreign invader or cancer cells. Know your vital signs. What is a normal heart rate? What is a normal blood pressure? What is a normal respiratory rate? And what should happen to these numbers when a person's exercising? If you're exercising with a patient or walking a patient and their blood pressure drops, their heart rate drops, this is a bad sign. When we exert ourselves, our heart rate needs to pick up, our blood pressure needs to pick up in order to meet the demands of our bodies for increased oxygen. These numbers are dropping. This is a bad sign. You're going to stop your treatment right there. So, ICU, let's review some of those things there. Pacemakers. What are the precautions for pacemakers? You should know these. Acutely, shoulder flexion, less than 90 degrees, not lifting more than 5 to 10 pounds, no driving. Longer term, avoiding magnets. You're not going to stick someone with a pacemaker in an MRI. MRI would be pretty bad. Oxygen levels. What's too low? At what level do we need to give supplemental oxygen? Probably around 87%. What if that oxygen level drops close to 70? This is a really bad sign. If it's getting that low, that's a sign that there's not enough oxygen in the body to keep the brain alive. You have a patient, their oxygen level is 72, you want to get the nurse, you want to get the PT. That is a dangerous situation. Remember, with oxygen too, it requires a doctor's prescription, and the level of oxygen that a patient is getting, whether it's 1 liter, 2.5 liters, that is a prescription by the physician. We cannot change that. The exception to that is if they are trying to wean a patient off of oxygen or do a trial on room air, no oxygen, and see how they do. And that would be something that would be ordered by the physician as well and communicated to you by the PT or the nurse. ICU lines. Remember, an IV line is just intravenous. You just want to be careful not to pull on the insertion there. If the patient has an arterial line, that's something that's firmer under the skin. They're going to be drawing blood gases from it. You don't want to bend the joint right near there. A PICC line is a long-term line. This is something someone can go home with. It goes in and deposits centrally. So again, you do want to be careful that that doesn't get pulled out. You're not bending right where that line crosses. A chest tube. So a chest tube is used when you have a pneumothorax or you have fluid that gets into the lungs, either air or fluid that gets into the pleural membranes. If you remember, there's a pleural membrane that goes around the lung, and there's a costal membrane that goes around the ribs, and there's some fluid in between those two membranes. They stick together and they help hold the lungs in an expanded position. If air gets in to that space, the lung can collapse. Or if fluid is accumulating in that space because of an infection, because of bleeding, multiple causes, the lung will collapse and they can put in a chest tube. So the chest tube is where they cut between the ribs and they have a tube that comes out to a drain. So you want to be careful with a chest tube drain. You don't want it up at all. You want it down at all times because gravity is pulling fluid out. You don't want to dump it back in. Also, should a chest tube come out during a treatment, that's an emergency. You want something sterile, sterile gauze, something to block that opening. That's just going open right there into the lungs. That's dangerous. And you want to get help immediately for that. NG tube, nasogastric tube, or a PEG tube, percutaneous gastrostomy tube. These are feeding tubes. So you're not going to want to put a gate belt around that person's midsection. Blah! That's where their food is going in. They're full there. You're going to want to put the gate belt under their arms. Other precautions we have here. Let me remind myself. A Foley catheter. A lot of people have these all over the hospital, not just in ICU. So a Foley catheter is when they put a catheter in up through the urethra and they inflate a balloon on the side that holds it in place. And then the catheter, the bag hangs low and that collects urine. You just want to keep an eye on that. Typically when I would go in and see a patient, I'd check for a Foley and right away get that positioned hanging on a walker or out of the way. In general, when you have patients that are in ICU, you want to get them out of bed on the side of where all their tubes and their lines are coming out of. You might have to move some things around to get it all to one side. You want to avoid kinking those lines, and you want to work with the patient. Continue in talking with the patient, that's what I want to remember, tracheostomy. So with the tracheostomy, what's the precaution there? They've created a permanent hole here so they can hook the person up to a ventilator, if they can find one these days. And that person's not going to be able to talk. They've got a hole in their throat. And they'll nod yes and no and communicate in other ways. With the trach, what you want to avoid is excessive cervical range of motion. So the patient writes on their little whiteboard, their neck is sore. You don't want to have them doing big cervical range of motion. You want to keep that neck pretty still because of that tracheostomy. I think I've hit most of them here. All right, well that just gave you, hopefully, general review. Make sure you know those labs. Make sure you know what to do about those labs. The exam 3 I'm going to be scheduling for next week, so good luck. Please give me feedback on this video if it was helpful, and hopefully I get to see you guys again soon. Thanks for listening.